this, I'm going to give like an improvised speech because I'm actually giving this speech in Illinois. They have asked us to present on migrant farm workers there on a national level. So it was really neat because not only are the border communities recognizing the need for this, but as I'll show later in the presentation, the migrants that travel all over the United States are really increasing in numbers too. And so the need for culturally competent services all over the country is something, and also Ricky will talk about. The border, many of you know, 2,000 miles stretching across, and 67 people live on it because we define it as 100 kilometers in both directions. Most of them are city sisters is where the populations live, and then a lot of nothing in between. Of the $28 billion fruit and vegetable industry in the U.S., 85% is hand-harvested or cultivated. And that figure, I think, is from like the 90s, so I would venture to say that after NAFTA, the North American Free Trade Agreement, the industries in the United States increased, the industries in Mexico decreased, so that figure is probably even higher. And that really affects why, when we talk about migrants, why the need to cross the border is there. And so when we talk about why people are doing the things, there's always a reason. I like to just step back and give a context for why there's such a disparity of wealth between the United States and Mexico. It's because we created it. In comparison with the U.S. population, I think the average age of migrant farm workers is about 31. Hispanics are about 16% of the U.S. population, but they are something like 65% of the border population. Obviously very poor, lower levels of education and health insurance, and as I'll talk about, higher rates of infectious disease, including HIV. So this is hopefully clear. The red is the rate of HIV among that population in the U.S. in general. The yellow is the rate of HIV on the border, and the blue is the proportion of that group in the United States. So you can see in terms of United States population, white are the highest, and then they are underrepresented in HIV, like they go lower, right? And then Latinos, who make up this much of the U.S. population and this much of the U.S. HIV rate as a whole, are way up here on the border, and that's what makes your work very important. And then blacks, obviously hugely overrepresented in the U.S. population and not as much on the border. Where workers go. And the western stream, where they start generally in California and Arizona and move up, California, Oregon, and Washington are by far the most populous states for migrant farm workers. This one we call the most divergent stream, because when they start in Texas, sometimes they go west, and sometimes they go east, and sometimes they go north. So where they end up is very much dependent not only on where they want to go, but where they're trucked to go by the growers. Florida, there's not as many crops up there. There's a little bit, but most of them stop about here in the mid-Atlantic states where tobacco and certain vegetables are there. So again, California has 4 times the number of migrant farm workers as the next most populous state, which is Texas. And you can see Washington and Oregon are here. North Carolina is rising on the charts. They're really increasing in number.
I have a question.
Yeah.
Go back to the other one.
Sure.
Is that only, are those arrows only significant to those folks coming from south of the border? Because I know Florida gets a lot of folks from the Caribbean.
Yeah, no, these are
also on migrant workers.
These are anyone who migrates, and by migrate, we call anyone who travels more than 75 miles in order to obtain work. So these are farm workers that are U.S. born in any country outside of the U.S., who come here to work and keep following wherever the crops take them.
Okay.
We know that most farm workers are male, and so women are usually employed either seasonally in farm work on local areas, and then work in service industries and stay with children. And so the HIV infection among those women generally happens through their partners when their partners return. And that's an important thing to remember in terms of intervention strategies. And we'll talk about that in a second. Some workers are paid by the hour and some by the piece, which this is what I've heard just leads to huge exploitation because it's obviously very crop dependent. And then when the crops need to be harvested, there's just a lot of hours that need to be crammed into maybe a 2-week span. So the conditions are just horrific. In general, the farm worker health concerns are related to their housing standards, which are often little camps set up, or even they're homeless, and so we know that in general a lot of their health problems, I mean, HIV is on the list of health problems, but actually the health problems that they face more are related to infections like TB that they can get in such close quarters. A lot of times when you try to intervene regarding HIV, there's this quick response, I'm not gay. And so one of the things that Border Health does that really addresses this is we have a training for what we call silent populations. And that's men who identify as heterosexual but engage in sex with other men. And whether they are open about that or not, that's their primary identification is heterosexual. And usually you can't get to this fact unless when you're talking one-on-one with someone, you say, are you having sex? And they're like, do you have sex with other men? Sorry. And they say, no. And then, well, do you have sex with women? They're like, yeah. And then you say, well, so you've been on the road for 6 months. So you're saying you've not had sex in 6 months? And they're like, oh, well, no, yeah, I have sex. And then you say, well, who has it been with? And then they start to talk to you about who they have sex with. So I think the conceptualization of who you usually have sex or who you'd ideally want to have sex with is not generally configured when you just have a broad question like, do you have sex with men at all? So when you want to address what the populations are in need of, it needs to be one-on-one and very specific at that level. I also like to talk about needle sharing because a lot of people think of people on the border as drug users and drug traffickers, and a lot of times for migrants, the reason that they're using needles is for injecting vitamins, by far, vitamins and medications. And so, to me, part of the stigma that we need to address with HIV also is to take out the factor of illicit drugs and just to emphasize that these are people that don't have regular access to nutritious foods and use this as a supplement just to get by. And then there are cultural things that are also interesting, like the belief in the superior efficacy of an injected vitamin versus an oral vitamin. So sometimes when you do interventions with workers and if you want to reduce their needle use, you can talk about the ways that equally efficacious drugs may be taken, but you have to recognize that there might still be a perception that needles are a better technique. No sick leave means you don't miss work. So when you're sick, you don't get services. And that also includes children. Actually, in addition to SB 1070, there's a lesser-known bill called Health Bill 2008, I believe, and that's mandatory reporting for health professionals. And so if I am an undocumented migrant worker and my child was born in the U.S. and is a U.S. citizen, I'm not going to be really excited about taking my kid to the doctor because I might be reported. And then who knows what will happen to my kid. So in other words, the issue here of going to the doctor is not just an issue for farm workers, it's for their whole family. And then states vary in providing out-of-state Medicaid benefits. So even if you had, say, Medicaid in California, when you migrate outside of California, or any other state for that matter, you can't take that Medicard, which is a federal program, you can't take that Medicaid card and go, I want services in any state because it completely varies. And so if you keep confronting that, obviously the next time you need services, you're like, well, should I bother to go to the health department? Because I don't even know if they're going to take me anymore. So it's just created barriers upon barriers. And there are free services. The federal government actually funds a few dollars to centers that work with migrant farm workers, but they're not necessarily, not all workers may know that those are places where they're not going to be asked for their status. And so they may be safe places, but the global perception of anything funded by the government or anything related to the government being dangerous is a barrier. A lot of times engaging with sex workers or engaging in other types of drugs like Demerol and other things that they inject may be a coping mechanism for depression and pain. The Health Bill 2008 Employment laws, very few migrant farm workers have workers' compensation, let alone long-term disability or sick leave. Inflammatory misinformation. We talked about the fact that actually a lot of times the diseases like tuberculosis or hepatitis are coming in. And I also just want to say that I've been careful about the audiences in which I bring that statistic, because sometimes it fuels greater xenophobia, because it's like, oh, all those foreigners bring disease in. So when I'm talking with a population that may not understand the greater context, sometimes I feel it's important to give, an understanding of why that is, what the services are like outside of the U.S., and then what happens when a population comes into the U.S. with different types of infectious diseases. Programmatic. So we know that funding is tight in this economy. The U.S. government has severely cut its budget for social services. And also, it's hard to get funding for grants when you're not working with U.S. populations. A lot of grants are written to serve Americans. And so I've had to phrase my target population in terms of I'm not asking, I'm treating the person, and it may include someone who's not an American citizen. Getting around the fact that you're actually serving someone who might not be an American is necessary in order to access certain funding sometimes. There's such a thing called a MIVIA program, and it's really cool. It's linking little clinics along migratory routes with electronic health records. So in other words, regardless of who you are, where you're going, if you go to these clinics, at least that have the MIVIA program, and you give your name and your birth date, not social security number, they can look up your record. And that way, if you have a history of this or that, and you need services that are continuous for chronic disease, for example, they have a lot of numbers for who you saw at other clinics. This is building partnerships, in my view. That's a great way to do that. National Center for Farm Worker Health has a website where you can actually enter your state and pull down and look at all the organizations in your state that serve migrant communities. So if you find yourself working with, for example, New Mexico or California or other border states, that's a resource that I thought would be important.
All right. What I want to do is talk about Border Health Foundation's Capacity Building Assistance Program. And I'm not going to be talking about demographics or epidemiology or statistics. What I'm going to be talking about is how our services can help organizations build their capacity to implement effective evidence-based interventions or other public health strategies or other types of HIV prevention programs. So just a real quick history. Border Health Foundation has been around since 1984. We're based in Tucson, Arizona. We started on the Arizona-Mexico border, expanded our services to the U.S.-Mexico border, and were subsequently funded to work on a national level through a Center for Disease Control grant, in which we began providing capacity building assistance to within the south region of the U.S. to community-based organizations and health departments. And I'll expound more on what capacity building is and how you guys can acquire services. But so after we were funded to work in the south region of the U.S., which is comprised of 13 states, we were then funded to work nationally with organizations and health departments that serve migrant farm workers in the U.S. and the 8 territories as well. That funding came to an end in 2009, and then we were awarded again by Centers for Disease Control to continue providing capacity building assistance on a national level, but to organizations that work with all types of communities, gay, straight, transgender, any type of IDUs. If your organization works with transgender populations, with whatever the risk category is, we can help you, or whatever the race ethnicity of your target population is, we can provide services for you. So just to take a step back real fast, we've over the past 26 years have provided over 70 public health programs. So we've done things like HIV prevention, domestic violence, substance abuse prevention. We've had youth groups. We've done parenting programs. So we've worked in a whole bunch of different areas within public health. So from a quick standpoint, we've been doing capacity building on some level since 1986. Border Health Foundation was initially started as a partnership between, in the University of Arizona and universities in Central and South America. So what we did initially was bring nurses from Honduras and Guatemala to the U.S., train them, and then they would go back to their countries and implement whatever skill sets we provided to them via this capacity building. And then throughout the years, we did like capacity building within like funding, for example, funding small organizations through small grants, and then providing technical assistance to promotoras in Mexico who were implementing HIV prevention programs, to maquiladoras and schools to young kids. So we've been doing capacity building pretty much throughout the past 26 years. To give you a real quick history on capacity building assistance and why it's such an important program, back in 1989, CDC began the funding national minority organizations. So in other words, what started to happen is when they started to look at the epidemiology, they started to look at the statistics and said, well, this HIV thing is moving out of the white community, and we're starting to see a lot of numbers in minority communities. So it was a red flag to them. So what they started to do was to fund minority communities. I mean, to fund, like, for example, black organizations because they had their pulse on, and they had those relationships in the black community. They started to fund Latino organizations because they had that relationship with the Latino community. So they were funding organizations that had these relationships, but the only problem is that what they were seeing is that there was this real big challenge with the programs the package programs that existed, because they weren't developed for minority communities. So what CDC did is that they began the capacity building assistance initiative, where they funded organizations that had the capacity to go in and help organizations to develop, evaluate, implement, adapt evidence-based interventions, or to even be able to better implement public health strategies. So that's a real quick, brief history of how capacity building came along. And one of the things I do want to emphasize is that we do help organizations that work with high risk or at risk, hard to reach racial, ethnic minority populations. So that really is sort of our calling. That's what capacity building is designed to do. So really the goal of what we want to do is to improve the performance of the prevention workforce, whether it's community-based organization or health departments, so that, again, subsequently, people are able to implement culturally and linguistically appropriate and sound prevention strategies and programs to the populations I just mentioned.
Okay, well, I want to share with you is a little bit about what the Regional Center for Border Health does in Yuma County. And it has been around for more than 16 years. And we do provide health education. We have prevention campaigns. This is actually one of our presentations that we had a couple of weeks ago at the San Luis Rio Colorado and Yuma County Binational Council. And we do these 4 meetings a year, and they are with San Luis, Mexico. So we work really well either in San Luis, Mexico, or in Somerton, or in Yuma is where we meet. And this is what we presented pretty much. We have clinics in Somerton and San Luis, and we had like immunization campaigns, March 1st, the 3 and the 5th of 2010. We had 59 children that attended the campaign, and we had over 158 immunizations that were administered. Now all these are shots that the children need to have their shot records updated, and so they can get into school or just continue that services. And it's kind of sad. Sometimes we have a small child that comes in and the mom just never took the baby into the clinic, and they have like 6 or 7 shots that they never had, and the doctor, the pediatrician, can't let them go. He's like, we have to give them the shots because then the mom might not come back. There was a U.S.-Mexico Binational Health Council meeting that took place in El Paso, Texas in April of this year. And this is where the secretaries of the health departments from the states on the border side of Texas, New Mexico, Arizona, and California, and then on the southern part, and the Mexican part, Sonora, Tamaulipas, Baja California, the governors got together, and also the secretary of health departments, or the departments of health, got together. And these are some priority areas that were discussed. obesity, diabetes, tuberculosis, teen health. A lot of these things are main issues that are actually being targeted in these areas. And there's actually programs already in place. People are doing something. There's organizations like ourselves and the local entities that are working together. And but it was some things that was still discussed as far as like these are priorities that are happening here. And then currently this was in March, but I know this year we're still continuing with Yuma Breast and Cervical Cancer Coalition, which is we're raising dollars, a lot of funding for women that are diagnosed with breast and cervical cancer, and we provide treatment services and support groups. So we have like this is a fashion show that we had, and we had the survivors, you know, to get together in collaboration. So they show off the dresses and there's a nice fashion show that's in Yuma. That's very successful too. There was 160 participants that attended at that time. And more immunizations for kids. This was in collaboration with the U.S.-Mexico Border Health Commission. And this was also in April. And this fair, there was 82 children that were attended in the campaign, and about 220 immunizations were administered. Now, along with these fairs, or the immunization, it's also a healthcare component, health fair. So we have different organizations from the county that are there and provide information and services to the community members that attend too. Okay, this is a little bit of the outcomes of that campaign. 103 children that we're seeing, 59 still, you know, really high percentage of children that are not qualifying for access or don't have health insurance. Number of adults and number of adults with no health insurance. There it is again. And then we have an annual asthma camp. So we're very diverse with all different types of populations. And this one this year we only had 7 children that participated. We had years where we've had 18 or 20 children that are here from Yuma, and they're diagnosed with asthma, and they're between the ages of 8 and 11. And so we're certified through the American Lung Association to provide education classes on how to cope with asthma and how to find out what the triggers are for asthma, what to do when you have an asthma attack. And then in the camp it's educational, but then they also get to go horseback riding. And they go camping. We have the Marines that go out out there, and they put the cots and they put the tents, and they sleep overnight. We have campfires. It's very educational. It's very fun for them too. And we're also welcoming anybody in the community that wants to participate as well. And we also have a binational clean air calendar. So this has to do with environmental health, with the Department of Environmental Quality, Air Quality. And this is pretty much the students. This year I think we've had over 593 drawings from different elementary schools in San Luis Rio Colorado and in Yuma County. And out of all those 500 drawings, there's a committee that actually selects the nicest or the 13 most creative ones. And they're in Spanish or in English, but if they're in English, then they're translated into Spanish, and if they're in Spanish, they're translated into English. And so we pretty much designed a calendar, and then there's about 15,000 calendars that are made at the end of the year. So January of 2011 comes, and we give those calendars out to the community. And that's promoting clean air. They have phrases like clean air, stop pollution. We have a mobile health bus clinic. It's a San Luis walking clinic. Has a medical mobile unit that serves the Crossroad Missions, a homeless shelter, and we've seen 137 patients by Mr. McNair, and we have promotoras there that also provide information services to them directly. And then we have an after-school program from September to July, from last year to this year. It was pretty much a program that served 54 children. Pretty much children are getting out of school, I don't know, 3:30 sometimes, and there's nothing to do from them from 3:30 to 5:30 by the time the parents get home. So we did an after-school program at the Martin Luther King Center, and we had children that came, and we had activities for them, and fruit and snacks and educational small sessions, or helping them out with homework or tutoring them. So that was a really good success. So we're doing that as well. And this is another immunization and community health fair. We do these fairs throughout the whole year. If you remember, the very first ones were in March. This is in July and August, just recently. And we had 350 people that attended. There's over 34 agencies that participated. And we also have screenings, cholesterol, glucose screenings. Depending on the outcomes of those screenings, we refer them to the clinic, we refer them to special services. And there was 105 immunizations for 74 children. We also had a preceptors training. The Regional Center for Board of Health has been funded with the federal grant and state grant, which is the Arizona Health Education Centers. So we're in charge of providing health education to San Luis, Somerton, Yuma, Parker, Lake Havasu City, Kingman, all of the western part of Arizona. So we have funding that's available for community health and also for rotation students that are in their preceptorship. They're finishing medical school, physician assistant school, or pharmacy school. But within all of that, we have pretty much contacts with preceptors in Yuma, and I've been able to visit probably over 40 doctors or 40 or 50 doctors here in Yuma County, and asking them to provide rotation services. So when the student comes in, looks for a rural rotation, since Yuma is rural, it's considered rural, they can visit some of these clinics and have their rotations for 6 weeks or 8 weeks. And then we get them involved in the community. Maybe they'll fall in love with it and want to come back and have their practice here too.
In Yuma, Yuma doesn't have an AIDS or HIV problem. We don't have a gay community, and Yuma is not comfortable about talking these topics publicly or privately. This is a very conservative community. It has been in the past. I can remember when I was in college and I was working really hard on Title IX for women, sports for women. I was with a group that I worked with, we were able to get basketball and softball at Point Loma Nazarene College. And I remember how unaccepted we were and how hard it was to convince the powers that be that this was a good thing, because they were having to divide funds into programs that they had not originally planned on. And Yuma is gradually becoming more progressive. Anyway, let me talk about the legislature. Cut, 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 privatize. Cut, 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 privatize. Cut, 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 privatize. Government is supposed to be this big. That's all. There is no room for services for the poor. There's no room for services for the elderly. There's no room for services for the kids. Okay? That's it. That all needs to be privatized. That is the way the legislature is looking at government right now. That is where we're at right now. I have fought and fought and fought. I fought for education. We cut $1.2 billion out of education in the last 2 years. Access. Kids' care is frozen. Well, we had to unfreeze it, but now it's on a waiting list because we weren't going to get any funds from the Obamacare in 2014 if we didn't bring kids' care back up, or our health services back up to the 2008 funding levels. That's the only reason kids' care got back in there. That's the reason we're 700 million, or we were, now we're more, 700 million in the hole. If we put a tax on electronic service contracts, so if you buy a refrigerator, you buy a stove, you buy a stereo system, you buy a big screen TV, and you opt to have a service contract, and you put a tax on that service contract, it would pay for kids' care.
Wow.
Period. That's it. It would only impact those people who could afford to buy those items. Is it being done? No. Was it considered? Yes. Did we ask? Yes. Okay. So, those are the kind of obstacles that I face at the legislature every day. We have a whole list, 2 pages of loopholes that are in our federal, in our state government, in our state tax system that we could close. If we close those loopholes, we could fund nearly all the programs that we have right now and be out of our deficit. Or be extremely closer to meeting our needs. Now, our revenues are down, yes, okay? But with all these loopholes, we could at least bring it up and be balanced, but nobody will look at it. The other thing they won't look at is we've given tax credits to huge corporations, big businesses, for a number of years. Well, those big businesses had promised to employ so many people at above the minimum wage, provide benefits for so many people. This was the trade-off for those tax credits, okay? And what it would have done is those people were employed, so the tax credit we're giving the corporation are coming back to us from these employees in the way that they buy, the way that they purchase homes, all the things that they're going to do. Well, these businesses haven't played fair and aren't meeting their obligations. The last two tax credits that we have given at the state level have what are called hooks. In other words, and they've been solar companies. You have to provide this, 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 and this, and in return you get these tax credits. Well, there's hooks. So if these companies don't follow those, then they don't get the tax credit. In other words, our treasury is going to get those funds one way or another. So you can also call it an incentive to make sure that you're employing the people and that you're following through on your half of the obligation. So those are the kind of things that are happening at the legislature. And those are the kind of things that are going to impact HIV, AIDS, all the triggers and all the social, what did you call them? Yeah, all the social determinants as to whether people are going to use alcohol, use drugs, and use the system. Because if they don't have jobs and they don't have services, that's where they're going to go. They're going to go in those directions to get away from what is expected. I stay home, I make tortillas, and I have babies. So I have worked and worked and worked. When I first started coaching, I would coach at the junior high level, and those girls would not go into sports when they got to Yuma High because they didn't want to have a physical. I fought that for 3 or 4 years. Finally, when they started offering physicals at the school and the kids could afford it, they were able to get into that. Once they get into something at their school, whether it be clubs, whether it be athletics, whether it be any kind of groups, a student council, any of those, you're going to keep them away from drugs, alcohol, improper behavior. That's been my push and my goal forever and ever. I was at a softball game or baseball game for my grandson just recently, and I had a mother come up to me and she goes, "You had my daughter in kindergarten and you told me that she was just so well coordinated and she was such a good athlete. I want to show you what she's doing. She's playing on the Mexican women's soccer team in Junior Olympics." Wow. I was so pleased. I just about cried. Anyway, and it was empowering that mother to make sure that her daughter got into soccer at those 5-year-old little games that you go to all the time, and then keeping her involved in those athletics all the way through. Those are the kind of things that keep kids off drugs without having all the, drinking, alcohol, sex, unprotected, and all those things that cause HIV and AIDS. So those are the kind of things we need. And now my niece is down at San Luis High School teaching health, and she is working very hard at the same thing, trying to empower girls and women to make sure that they are responsible for their own bodies and they don't have to take orders from anyone. So that is still my goal. That Mike said, some of these girls don't realize that they can say no. I mean, they've never been taught that they can say no.
All right, I'm Floribella Redondo. I'm actually the programs director for Campesinos Sin Frontera, a nonprofit agency in Somerton. Our mission of Campesinos Sin Fronteras, I always like to think about our mission of just what really stands out is the self-sustainability, to teach a person to be self-sustainable. I think that that's our main goal, and our vision is to advocate and foster long-term strategies. What we do in the community is trying to bridge the services with the needs, and also personal knowledge. Changing behaviors is one of the ones that we really try to target, and because we know that changing behavioral impacts in every stage of our life. So this is part of the programs that we offer. We have, just like Border Health Foundation, just like Regional Center, we have an array of programs that we offer to community members. And we service the border of San Luis, and also we have crossed into the Mexican side, and we also service over there, provide our programs, and we have a collaboration with some providers in Mexicali as well, in Baja California. Well, we have approximately 90,000 farm workers in Arizona. Out of those, approximately 46, they live and work here in Yuma, in our community. And this has been impacted by all what you were talking right now, because more and more we see that a lot of the farm workers that used to migrate to Arizona from California or migrated from Mexico to come and do the corrida, the season here, and this, they don't come anymore. Just because they're afraid of the SB 1070. It has impacted so much our community and our lives, and actually the services that we offer have been impacted as well. Because funding is really scarce. Funding is shifted to the areas that where they're staying because the need is greater now in some other areas, so they're taking some of our money to provide for them. Well, what I'm going to be talking about, Emma asked me to talk about our Promotora program today and our HIV program that we started in '96. Our Promotora program began with 15 volunteers that farm workers, all of farm workers, that wanted to come and learn about what HIV was. We wanted to be a model, wanted to be a volunteer and go back into the fields and educate the peers about what they have learned. I was one of those volunteers, and I was myself, I'm an ex-farm worker. I worked in the fields for 23 years. We started our first promotora. Do you know what promotoras are, first of all?
I don't.
Community health workers? Okay, the community health workers, lay workers. We started with our group in '96, and our first training was provided by the Farm Worker Justice Fund, run by Shelley Davis in Washington, D.C. Shelley died last year, and she was an advocate for the farm worker community. And she was always looking for groups in the border town or wherever she could find them that were working specifically with the farm worker community and trying to bring the capacity so they could be sustained in their community, and they could also train and look and do what these snails do. They always come around and around and around. So trying to impact everybody around you, your environment could change. This is actually one of the first pictures of our promotores that worked. What you see in the top, I'm going to talk about the flowers right there in the basket. I'm going to talk a little bit about them right now. We did the outreach. We always do outreach into the community. This is the way that we do it. When we service the farm workers, we go where they're at. We go to the fields, we go to pickup sites, and we go during the summer, the winter, whenever they're working, we go back. We have a really good relationship with all the growers, with the supervisors, the foremen, and that's not really science because we were all farm workers ourselves. So we have the relationship, we know them by first name, they know us by first name. So when we go back into the fields and they let us talk because they know that we're not going to talk about their rights. We do have workshops on know your rights, so they can know their rights as well. But when we go out, we educate on specifically respecting the time that they provide us. We talk to the farm workers on the issue that we're taking that day. And we talk to them about the HIV issue. And I just want to say that that before we had, like I was saying, we had so many farm workers, we couldn't reach them all because we had like 45, 46,000, and we would go every single day into the fields, not because all these issues that have brought Arizona into the forefront of all the TV stations and be in the news. We have a lot of H2A guest workers now.
Yes.
And more, increasingly every single day, we have the guest workers that cross, and now we have to manage to see, are they crossing, are they staying? We now know where they're staying and what hotels. In the afternoons, you drive 4th Avenue, you will see the groups of H2 workers waiting for the next day to go to work, doing nothing. So we work with them, we educate them, and we provide them what services we have as well. And one of the things that I also want to mention is that during the summer, our unemployment rates just are skyrocket high. We have in San Luis, Arizona, 70% unemployment rate. And that increases everything else. Domestic violence, increases substance abuse, increases emotional health. It's just a problem that just escalates every single year because we are working with them, but where can we refer them to? Lynn was just saying, we don't have services, they're cutting back. They just cut, how
Poor.
many?
If you're poor, you're elderly, you're disabled, or you're a kid,
Yes,
forget it.
all the severely mentally ill, they cut their funding.
Yes.
So a lot of the persons that we could refer before because they were depressed, they were suffering from a disease, now we don't have a place to refer them. So we have to rely on our community partners. We work with Regional Center, with the Sunset Clinic, with Chicana por la Causa, KPEP, YPEC, but we know that
Excel,
Excel
and
Simpatico.
and Simpatico.
And Simpatico, yeah. And now it's Superstition Mountain
Yes.
that's working with us in trying to really service this community. We collaborated with the health department for 2 years. We were certified to do the OraSure testing, and then we went to be certified to do counseling, and then we went to be certified to do the rapid testing with them and everything. So we did okay. We were providing the education, we were providing the testing in San Luis, Arizona. Every month we would have a set date that we would be in San Luis, Arizona with the health department doing testing. The first time, 1 or 2, the second month, a little bit more. But as soon as it was more openly, we would have more persons. And then we said, okay, I think it's accepted now. Let's do it in our health fair, our biggest health fair that we have, that's the Day del Campesino. The Day of the Farm Worker, the Campesino does every single year, the signature event. We provide services from 3 a.m. to 10 a.m. and to approximately 5,000 farm workers. And we have approximately like 67 agencies that come together to bring their services to the park at 3 a.m. Actually, they get there at 2. And we have help, any kind of information, any kind of service that we can have in the community. From Phoenix, Tucson, they come and they offer that day. And legal advice, anything that you can think about, and we can get. And it's getting harder to get those services because of funding. And we have music, and we have a lot of folklore, just the culture there. We have the breakfast for them. And we said, okay, how about if we do a Shabi, and we celebrate the World AIDS Day during the Dia del Campesino. It wasn't going to be the same day. So we did World AIDS Day during the Dia del Campesino. And to our surprise, we were the ones that we didn't want to see probably. To our surprise, the first time that we had World AIDS Day in Dia del Campesino, we had 126 people line up to do the HIV test.
Wow.
To get
It
tested.
was, yes, it was for us, it was like, oh, we were wrong. We thought that people were not going to come. We had 126 waiting. They waited there for hours to be tested. The thing back then that we could do the confidential and anonymous part, so that was the point we said, we're not doing anonymous anymore because we had one person that tested positive. And so the health department had to work extra to find that person. So that's why we said, okay, we're doing confidential from now on. But I think that it was good. I think we broke barriers. We continue working. We promoted the prevention. We brought together Red Cross, other agencies that were working together.